Welcome to the invited guest lecture series of the Department of Oral Pathology and Oral Biology of the University of Pretoria. And we are indeed really thankful that we have today Dr. Lisa Rooper to chat to us. Before I'm going to introduce Lisa, just one or two housekeeping rules. You see that you have all been muted. So, and Lisa has agreed that she will take questions after the talk. So as usual, if you can make use of a chat function to type your question and we will address it thereafter. Thank you very much. Lisa, as most actually needs no introduction. She's a head and neck pathologist, as we know, and a general surgical pathologist at Johns Hopkins Hospital in Baltimore, Maryland. She specializes in the pathological diagnosis of diseases of the upper aerodigestive tract, sinonasal tract, salivary glands, thyroid, parathyroid glands, and associated soft tissue. Our research interest obviously focuses around these entities as well, with emphasis on improving the diagnosis of these tumors, classification and prognostication of these tumors. She is currently also the director of the Head and Neck Pathology Service and Assistant Director of Surgical Pathology of Johns Hopkins. She's on the editorial board of several eminent journals, including the American Journal of Surgical Pathology and Modern Pathology. Lisa, again, thank you for agreeing to talk to us. We are grateful for your time, and the floor is yours.
All right. Thank you so much for the introduction. I'm so excited to be here and talking to you all. And I always have to add, I really appreciate when I'm talking to an oral pathology audience. I've had so much help and support from the oral pathologists at my institution, especially when I was kind of flying solo here near the beginning of my career. So I really value the oral pathology world so much. Today, I am going to be focusing on the sinonasal tract and have no disclosures. We'll start out with saying that. Now, of course, sinonasal tumors are a perpetually challenging group of entities that I think, all of us run into similar struggles when we're dealing with them. Frequently we get very small, crushed necrotic samples that the surgeon has tried to take in the office to give us to do our best with. And a lot of these tumors all have the same morphology, small round blue cell tumors, very undifferentiated, hard to make a diagnosis based on just H&E. Of course, diverse tumors of multiple lineages can involve the sinonasal tract. So we have to think of a lot of things that can arise throughout the body, soft tissue, melanoma, hematolymphoid neoplasms. But of course, there's also multiple tumor entities specific to the sinonasal tract. And today, what I really want to focus on are some of the very emerging categories in sinonasal tumors that have resulted from molecular analysis and have really allowed us to understand the tumors in this category better. Molecular testing has kind of changed several things in the sinonasal tract. It's allowed us to recognize new entities that are actually defined by their molecular alterations. It allows us to define and I should specify, recognize entities that can occur elsewhere, but also occur in the sinonasal tract, but also define new sinonasal specific tumor types, as well as sort of explaining better what's going on with existing tumors and what the pathogenesis and classification is. So, and I'll also add a word of warning. I'm focusing mostly on changes in the carcinoma categories today because that's where a lot of this molecular classification is emerging. And right now, all of these categories, they have pretty large prognostic implications. They're really helping us figure out which sinonasal tumors are likely to be more aggressive and which ones are likely to behave a little better. But the treatment utility is still emerging. I think it's down the road. I think there's some really great targets that are happening. But really, the biggest, most impactful diagnostic distinctions you can make in sinonasal pathology are the things I'm probably not focusing so much on here today. That's differentiating carcinoma from melanoma, from lymphoma, from rhabdomyosarcoma. Those are the things that are going to initiate massive differences in treatment today and are still, the things that you want to have on your radar, the highest threshold for distinguishing kind of before we jump into this molecular world. So I'm specifically going to be talking about kind of 4 different areas: tumors that have squamous differentiation, the switch sucrose non-fermentable complex deficient tumors, IDH mutant sinonasal carcinomas, and then an emerging category of olfactory carcinoma. So I'm going to start out talking about tumors that have squamous differentiation, and I'll just kind of begin by saying it's pretty amazing that we're sitting here talking about different molecular categories of squamous cell carcinoma, because I think for a long time, sinonasal squamous cell carcinoma was considered to be analogous to squamous cell carcinomas in other head and neck and other aerodigestive sites, very P53 driven disease. However, the risk factors for sinonasal squamous cell carcinoma, have always been poorly understood compared to other sites. There's been a weak association with cigarette smoking compared to what you see in the oral cavity or larynx, and the association with occupational exposures is not nearly as strong as it is with other sinonasal tumors, such as sinonasal adenocarcinoma. Sinonasal papillomas have been known to be a precursor for sinonasal carcinomas, but the mechanism of initiation and transformation has been unclear, and the etiology for other cases of sinonasal squamous cell carcinoma has been totally unknown. But there's 3 kind of emerging molecular pathways. HPV is one of them. Sinonasal papillomas, and specifically EGFR mutations that cause them, and also fusion-driven carcinomas that have squamous differentiation. And I'll touch briefly on all of these. So first of all, HPV is we all know its role in head and neck squamous cell carcinoma in general, and it was originally recognized to have a role in the oral pharynx, and it has traditionally been thought of as specific to that site. With up to 80% of oral pharyngeal squamous cell carcinoma in the United States, the incidence tends to be a little lower in other locations, and the incidence has increased in recent decades. And the thought historically was that HPV was rarely seen in other head and neck sites, and as such, College of American Pathologists, other recommendations that we really only test for HPV in oropharynx and neck lymph nodes when we're working up unknown primaries. However, HPV has emerged in the last few years as a second hotspot, or to have a second hotspot in the sinonasal tract. Most recent studies report a range of 20 to 25% of sinonasal squamous cell carcinomas are HPV positive, but there's a range in literature between 5 and 70%. So pretty broad spectrum of attribution of sinonasal squamous cell carcinomas to HPV. And this is really the highest prevalence in non-oropharyngeal sites in the head and neck. And it is also now regarded as the most common defined risk factor for sinonasal squamous cell carcinoma. And the pathogenesis here is very similar to what we see in the oropharynx: transcriptionally active HPV that's driving the viral E6 and E7 oncoproteins and associated cellular proliferation. Now, what's interesting, one thing that we've noted very recently that we have a publication in preparation for, is that the rate of HPV involvement has actually seemed to go up over time. An older study from our institution said it was about 20%, but as we've tracked it over time, it's actually gone up. And now, it seems to have ranged when we parse it out by year from about 10% in the 1990s to about 50% in 2020s. And this actually parallels some other studies that have been done on more recent patient cohorts and have found higher rates of HPV. So it seems like, similar to the oropharynx, the rate of HPV involvement in the sinonasal tract has increased. And HPV-associated sinonasal squamous cell carcinoma is a non-keratinizing squamous cell carcinoma, very similar to what we see in the oropharynx. Lobules tend to have a very pushing pattern of invasion, can be sort of papillary, not necessarily highly infiltrative, and fundamentally non-keratinizing squamous cell carcinoma. P16, of course, is consistently positive. I will throw out there that P16 is not as specific in the sinonasal tract as in the oropharynx. So using P16 as a standalone marker for HPV in the sinonasal tract can be hazardous just because a lot of other sinonasal tumors are P16 positive. And of course, HPV-specific testing, such as RNA in situ hybridization, is also nicely positive in these tumors and is necessary to confirm HPV involvement if you are testing, which you don't necessarily need to do at this point. And I'll get into that here. So prognostic implications. Single institution studies, several of them have suggested a slight benefit of prognosis with HPV involvement, but it was always sort of borderline in terms of whether that was significant. Now there have been a couple larger national cancer database-based studies that have confirmed a significantly statistically significant survival benefit for HPV involvement in sinonasal squamous cell carcinoma. Notably, though, the overall survival is still inferior to oropharyngeal squamous cell carcinoma. So even if HPV positive does better than HPV negative, they still don't do nearly as well as the ones in the oropharynx. As such, the clinical utility is unclear. Routine testing is not yet recommended in the sinonasal tract for HPV, and what might be one of the more practical applications is that there are emerging serum testing that allows clinicians to track HPV levels and recurrence over time. That's something that's very actively being used at Hopkins that we're doing all the time and is starting to really drive what we do for our HPV testing. But right now, this is not a site where necessarily you have to test for HPV, but we do know that it's a molecular driver. Now, I will say, though, there are tumors in the sinonasal tract that are defined by their HPV involvement. Everyone, I'm sure, has heard of HPV-related multiphenotypic sinonasal carcinoma. This is not strictly a purely squamous cell carcinoma, so I'm diverging a little bit from this category. It shows both squamous and salivary differentiation with a mix of ductal and myoepithelial components. And of course, it was originally described as HPV-related carcinoma with adenoid cystic-like features, but the name was changed as there was recognition that the spectrum was a little bit larger with varying morphologies. Now, these uniformly lack the MIB fusions that are characteristic of adenoid cystic carcinoma, the classic type, and instead are driven by transcriptionally active HPV. Interestingly, it's a weird HPV type, type 33, that is found in 2/3 of the cases and seems to be central to the pathogenesis. And here's a couple examples of it. This one is a very adenoid cystic-like multiphenotypic carcinoma with good cribriform architecture, but it is not always like that. Here's one that has sort of a more basaloid morphology with areas of necrosis floating around. And one thing that's very interesting about the HPV-related multiphenotypic sinonasal carcinoma is that there's frequently surface squamous dysplasia that's associated with it. So you can see the deeper aspect of the tumor has sort of the cribriform pattern, looks somewhat salivary, but it has this squamous dysplasia look on top, which can be a helpful clue to recognizing this tumor. By definition, kind of the salivary components show biphasic pattern, ductal and myoepithelial differentiation. So here we see a P40 highlighting the myoepithelial components. It would also be highlighting the more squamous and basaloid components, although I'm not showing that here, and the ducts are negative. And of course, this is a tumor where doing HPV testing is necessary for diagnosis, and this is HPV-33 RNA in situ hybridization. And of course, what's important about recognizing this tumor is even though it looks very high grade, very cellular necrosis, cytologic atypia, it actually does much better than most high grade sinonasal carcinomas. Approximately 1/3 recur locally, but there have been a very low rate of distant metastasis and lymph node metastasis, and only rare cases of death from disease. So it's a tumor that does pretty well, and it's worth recognizing to actually give the patients a good prognosis. All right, so back to the more strictly squamous lesions. Next, going to talk about, sinonasal papilloma, something I think all of us see regularly, of course, divided into 3 different types, inverted, exophytic, and oncocytic, inverted being the most common. And there's a risk of carcinomatous transformation. The numbers vary a little bit in the literature, but it does seem to be most common in inverted papillomas, up to 15%. In older literature, probably the accurate number is a little bit lower these days, 5% of oncocytic papillomas, and it's very, very rare in exophytic sinonasal papillomas. And there haven't really been reliable histologic features to predict malignant transformation, and no correlation between the number of recurrences and development of cancer either. Most often, squamous cell carcinoma is seen synchronously with benign papilloma, although it can occur in patients who have a history metachronously. And here's a beautiful example of an inverted papilloma with nice rounded nests and lobules of the squamo-transitional epithelium, characterized by lots of intraepithelial neutrophils, and of course has this, pushing rounded nests that extend downward into the stroma. Here is a squamous cell carcinoma, ex-inverted papilloma, and this is a low power view, trying to get some of the inverted papilloma component up at the top, but you get kind of more complex architecture, more confluent growth, and you're not seeing it at this power, but more cytologic atypia. Here it's an oncocytic sinonasal papilloma. Instead, kind of has this bilayered epithelium that has an oncocytic appearance and frequently has the little microcysts and microabscesses, some mucin production in here. And you can, of course, get squamous cell carcinoma ex oncocytic papilloma as well. And here's one that has a lot of cytologic atypia that we can see, as well as some infiltrative growth that's arising in an oncocytic papilloma background. Now, there has been longstanding controversy about the role of HPV in sinonasal papillomas. Historical literature, ranges from 0 to 100% of HPV involvement. There's been a lot of roles proposed for HPV. Does it initiate the papilloma? Is it implicated in its growth? Does it play a role in malignant transformation? All of these have been argued in the literature. And I think there's a lot of issues with the literature dealing with this that I think have really confounded the issue. I think a lot of older studies use PCR-based testing that identified some biologically irrelevant virus at low levels and called that positive. Some studies conflate low-risk and high-risk HPV types, which are generally associated with different pathways of disease. There's conflation of inverted exophytic and oncocytic papilloma types, which actually HPV plays different roles for. And some studies have had a lack of central pathology review and have even included HPV positive tumors that have a papillary configuration that aren't truly papillomas. So there's a lot of problems confounding the literature that makes it really hard to deal with. But recently, I think there have been several large studies that have led to emerging consensus on the role of HPV. At least 25 to 50% of exophytic papillomas are thought to be associated with low-risk HPV. That's pretty solid, and that one has stayed that way for quite a while. About 10% of inverted papillomas are associated with low-risk HPV. There's a possible higher risk of malignant transformation associated with these low-risk HPV inverted papillomas, although that's not set in stone yet. That's sort of an emerging association. Oncocytic papillomas are generally not associated with HPV at all, and high-risk HPV, transcriptionally active high-risk HPV, has minimal role in any papilloma subtype. So really right now, there's no indication for HPV testing in any type of sinonasal papilloma. So if not HPV, what is causing papillomas? It has become pretty clear, based on some really nice work out of the University of Michigan, that EGFR and KRAS mutations are the drivers. In inverted sinonasal papillomas, the vast majority have activating EGFR mutations, and that are also present in associated squamous cell carcinoma. And these are mutually exclusive with low-risk HPV. So the small percentage has low-risk HPV, the rest of them have EGFR mutations, and these are two separate groups. Oncocytic papillomas instead have activating KRAS mutations, and this is very consistent in both the papilloma and associated squamous cell carcinoma. Now, they're also the same group in Michigan has recently published on some features, additional molecular features that spur transformation to squamous cell carcinoma. TP53 or CDKN2A alterations are often seen in most cases and are thought to be kind of the additional genetic events that cause transformation. And these findings are not seen in the matched sinonasal papillomas. And overall, this profile, the EGFR KRAS mutations with the associated additional molecular alterations, are unique among head and neck squamous cell carcinomas and point to the papilloma origin. And hopefully this would also lead to treatment implications someday. EGFR mutations are potentially actionable targets of EGFR inhibitors. Unfortunately, most of them in papillomas and associated squamous cell carcinomas are exon 20 insertions, which are more resistant to treatment than exon 19 deletions, which we see a lot of in lung cancer and are targeted. But there may be newer drugs out there that work better. So it's something to hopefully will come into fruition in the future. And the final area of squamous cell carcinoma I want to talk about are fusion-driven squamous or tumors that have squamous differentiation. And there's three of these in particular that we're going to touch on. So nut carcinoma, again, this has been recognized for a while now, previously known as nut midline carcinoma because it has a proclivity for midline sites, but they took midline out of the name because it can occur anywhere in the body. Approximately 35% of nut carcinomas involve the head and neck, so it's a very common site for them, and in the head and neck, although they arise in multiple sites, they're most common in the sinonasal tract. Defined by translocations of the NUT gene, nuclear protein in testis is where that term comes from, so we have this very handy acronym. Most commonly BRD4 NUT fusion in 2/3 of cases, and the fusions are thought to serve to block epithelial differentiation and maintain proliferation in the tumor cells. Here's a nice example of a nut carcinoma, very primitive looking cells, high grade, prominent nucleoli, often arranged in sheets. A subset of them have very prominent tumor infiltrating neutrophils, which we see in this particular case. Of course, we always think of the abrupt keratinization as the pathognomonic feature for nut carcinoma, with these nice keratin pearls right next to these very primitive high-grade cells. And it's not entirely specific, but it is a beautiful feature to make you think of nut when you see it. And here is the nut immunostain, which is very sensitive and specific for diagnosis of nut carcinoma, and is really helpful for allowing us to quickly make this diagnosis in the sinonasal tract. Now, nut carcinoma, of course, is worth recognizing because it's a highly aggressive malignancy. Median survival is less than 1 year. It's really one of the worst tumors that you can get, and it's very common to have both local recurrence and distant metastasis. This one, is important to recognize because there are actually very active clinical trials targeting bromodomain inhibitors that target the fusion, and that is one very good reason to make the diagnosis of nut carcinoma and separate it out from other tumors with squamous differentiation. Now, the next tumor I'm going to talk about is not strictly a carcinoma, or at least we don't think so right now, and that's adamantinoma-like Ewing sarcoma. This is a rare variant of Ewing sarcoma. Most cases have been reported in the head and neck. Most common seems to be in the salivary gland and thyroid. It was initially recognized in the sinonasal tract in the head and neck, but that seems to be slightly rarer than the other sites. And it is defined by squamous differentiation. So it is super weird. It is doing all the Ewing's things. It's positive for CD99 and NKX 2.2. It has the Ewing EWSR1 Fly1 fusion, but it also shows diffuse cytokeratin positivity and P63 and P40 positivity. So really well-developed squamous differentiation, yet still falling into the Ewing category. Here's a beautiful example of an adamantinoma like Ewing. Tends to be these very infiltrative basaloid nests of cells that are trickling through sort of myxoid to fibrous stroma. Now, we talked about abrupt keratinization with nut carcinoma. It is also a feature of adamantinoma like Ewing sarcoma, so it's not an entirely specific feature for nut. Here's a nice little keratin pearl, and I will add, we don't see this every time. I actually feel like we see this in only a minority of cases, but it's something that's there in adamantinoma like Ewing sarcoma, and it can make you think of the diagnosis. The other important thing to recognize about this is that even though, this tumor can look high grade in some ways, can have necrosis, elevated mitoses, it actually tends to have pretty monotonous cytology. It's a fusion-driven tumor, and all of the cells look like they're kind of stamped out of the same category. Diffuse keratin positivity, and I will add, normal Ewings can have a little keratin positivity, usually not all the cells though, and adamantinoma like Ewing is positive across the board. Here's P40 positivity, also very, very strong and diffuse, but still having nice CD99 positivity, and again has the EWSR1 Fly1 fusion. Now, the real question is, adamantinoma like Ewing sarcoma really a variant of Ewing sarcoma, or is it just a carcinoma that happens to have the same fusion? The cytokeratin expression and diffuse squamous differentiation are suggestive of carcinoma, and there's been identical tumors actually described as carcinoma with Ewing-like elements. The EWSR1 Fly1 fusion historically was thought to be pathognomonic for a Ewing diagnosis, but this was actually, a fusion we recognized very early in our understanding of how fusions contribute to carcinogenesis. And now we recognize that you can have the very same fusion in a lot of different tumor types, and that even of tumors of different lineages, and several. So it's really a question mark as to whether this should be part of the Ewing spectrum. I will add that, there's not enough data out there to definitively comment on this in terms of treatment, but there are several patients who have responded well to Ewing-specific chemotherapy. So there is, some evidence that patients who have tumors with this fusion at least are responding to the conventional regimens. So that is kind of still a question mark, and we'll see how that goes in the future. But it's definitely a distinctive entity with squamous differentiation that's worth recognizing. Now, the final fusion-driven tumor in the squamous category is something very new, and those are tumors that are driven by DEC-AF2 fusion. And this is a kind of interesting story. This fusion was actually originally described in a basic science study that was looking at patients who responded really well to immunotherapy. And they found that one patient had a DEC-AF2 fusion and a big skull-base squamous cell carcinoma. And they actually found that there were neoantigens that were directed to the fusion transcript that probably helped spur the great immune response. But after that was originally observed, more of these tumors came to light. Elaine Weinreb and colleagues found a couple of them in the middle ear and temporal bone and kind of started to suggest that this might not be an isolated fusion, it might actually be an entity. So the DEC gene and AF2 gene are both unusual components of fusions. DEC has been implicated in a subset of acute myeloid leukemia as a driver, as a part of a fusion there. And it's also known to be an oncogene that's upregulated in various cancer types, including head and neck squamous cell carcinoma. But these sinonasal tumors are actually the first carcinomas that have been found to have this gene's involvement. AF2 is kind of even rarer as a component of a fusion. It's part of a family of genes. Some of its partners or some of its siblings are implicated in leukemia, but AF2 had not previously been recognized in the cancer setting, and instead had been really recognized in germline syndromes. So, once we kind of started thinking about these, that this fusion was out here, the question became how to find these tumors. And, there were only a few cases initially reported, and no one was really sure what the morphology was or if this was something we could recognize or definitively separate from other squamous cell carcinomas. Last year, we were able to put together a series looking at 27 non-keratinizing sinonasal and skull-based squamous cell carcinomas across 3 institutions. All of them were HPV negative, and all of them that were in the nasopharynx were EBV negative. And we found that almost half of them, 13, had DEC-AF2 fusion. So this fusion seems to be pretty common in that subset of non-keratinizing squamous cell carcinoma that is HPV and EBV negative. Importantly, 3 of them were originally called benign papilloma, and 3 of them were originally called squamous cell carcinoma X sinonasal papilloma. So these were actually tumors that some people thought were benign, and we were able to do kind of further sequencing than just looking for fusions on a couple of them, and there were no other known oncogenic driver mutations. Here's some beautiful examples of it to kind of give you a sense of what this tumor looks like. Tends to be defined by complex anastomosing lobules of squamous epithelium that tends to show very deep and pushing pattern of invasion into the stroma. Here is kind of illustrating that pushing pattern of invasion. So frequently the tumor nests have a very rounded border, but are still kind of showing destructive growth and pushing downward, very similar to what we see with other non-keratinizing squamous cell carcinomas in the sinonasal tract. They tend to show complex and confluent growth with areas of central discohesion. And this is a very important feature that can help distinguish them from papillomas, which tend to show nested growth with much more discrete nests surrounded by stroma. The DEC-AF2 carcinomas tend to be very complex growth, interanastomosing lobules. So it's a very more intricate and convoluted architectural pattern than you'll see in a papilloma. And another thing that's helpful is that where the lobules sort of intersect, there tends to be a lot of discohesion of the cells, and they start falling apart. And that actually is a pretty consistent feature that we see across these tumors. The cytology of these tumors, they're translocation tumors, and it tends to be very, very bland cytology, round to oval nuclei, very, very monotonous looking, not a lot of mitotic figures in many of the cases. And these are also tumors that have a prominent population of tumor-infiltrating neutrophils. And this is a feature that actually overlaps very strongly with sinonasal papillomas and probably led to the subset of them being misclassified as sinonasal papillomas before we knew what these were. Interestingly, we say they're non-keratinizing. They're not always entirely non-keratinizing. Some of them do occasionally have squamous pearls, but it's usually less than 10% of the tumor volume. And we haven't yet found any that are diffusely keratinizing, although who knows what will happen in the future. These are, show well-developed SWIMS differentiation, strong P40 positivity, then, of course, the DEC-AF2 fusion is there. So one question is how these are related to low-grade papillary Schneiderian carcinoma. And this is a term that was originally proposed by Jim Lewis as an emerging entity. I think there's about 14 cases in the literature under this term. And it's also a low-grade, non-keratinizing carcinoma that shows squamous differentiation, and that's defined by complex papillary architecture and strongly mimics sinonasal papillomas. And another study came out of Taiwan just about the same time ours did, looking at the DECAF2 carcinomas, and actually looked for the fusion in 4 of the cases that were previously reported as low-grade papillary Schneiderian carcinoma, and found that they all had DECAF2 fusions. So largely tumors with this appearance are now considered part of the DECAF2 carcinoma spectrum, and this is probably not a separate entity. So why is it worth recognizing these? Well, most of them occur in the sinonasal tract, but can occur across the skull base, nasopharynx, middle ear, temporal bone, all are sites. Despite their low-grade histologic appearance, they can behave aggressively. And that's kind of why it's worth noticing them, and also definitely worth recognizing that they are not just plain old sinonasal papillomas. In limited follow-up, they locally recur about half the time, and up to 40% of cases have distant metastasis, and as many as 25% in our series, I think lower in the other series, died from disease. So most of these, are not super aggressive tumors, but they do recur, and they're definitely not benign papillomas. One interesting question I want to touch on real quick is the potential for immunotherapy, as they were initially described in this paper, characterizing dramatic responders to immunotherapy. Unfortunately, a couple more patients that we're aware of were treated with immunotherapy, and did not, unfortunately, respond quite as well. So it's not clear that is necessarily a panacea for treatment of these, but obviously there's more opportunity for more experience in the future. So where do these go, before I move on to the next group of tumors? Where do these go in the new WHO classification? So non-keratinizing squamous cell carcinoma, both HPV-associated squamous cell carcinoma and DECAF2 carcinomas have been recognized as subsets in that category. And HPV-related multiphenotypic carcinoma, nut carcinoma are entirely separate entities. And then adamantinoma, like Ewing sarcoma, is a subtype of Ewing sarcoma. All right, so long dive into squamous tumors there. I'm now going to move on to the SWE/SNF complex deficient tumors. So of course, the SWE/SNF complex is a chromatin remodeling complex that's composed of 15 protein subunits encoded for by up to 29 genes. And the ones we talk about most commonly are SMARCB1 and SMARCA4. And SWE/SNF complex in general is known to play a major role in cancer. Mutations in at least one subunit is seen in up to 25% of human cancers. And overall, across the body, ARID1A is the most common subunit that's involved in cancer. The involvement of the SWE/SNF proteins can kind of fall into 3 different categories. There are tumors defined by the presence of SWE/SNF alterations, and that's a couple of the ones that I'm going to talk about today. There's tumor types with frequent but not exclusive SWE/SNF alterations, which is another tumor I'll talk about. And then I'll also note that it is common to see these alterations as part of the differentiation of high-grade tumors at various sites. So just some examples across the body of tumors that are defined by SMARCB1 or SMARCA4 loss. SMARCB1 we think of with rhabdoid tumor of soft tissue, atypical teratoid rhabdoid tumor of the CNS, epithelioid sarcoma, renal-medullary carcinoma, epithelioid MPNST, and SMARCA4 deficient tumors. The most common one we think of is ovarian small cell carcinoma, hypercalcemic type. But of course, these are now known to play an important role in sinonasal carcinomas. So SMARCB1 deficient sinonasal carcinoma, kind of simultaneously described by my colleague Justin Bishop as well as Abasagami, and was found to be an aggressive malignancy that's unique to the sinonasal tract that seems to be defined by SMARCB1 inactivation without any other recurrent oncogenic mutations. It is a variable immunophenotype tumor. Most are positive for P63 or P40, but a significant number are negative, and can also show some neuroendocrine differentiation. And these have been reclassified from several categories. A lot of them were previously in the sinonasal undifferentiated carcinoma category. Others were called squamous cell carcinoma, myoepithelial carcinoma, or even adenocarcinoma. And of course, majority of tumors kind of have a basaloid appearance with large nests and lobules of basaloid cells that kind of have intermixed cells that have a rhabdoid/plasmacytoid appearance with eccentric cytoplasm and round nuclei. Frequently, there's cytoplasmic evacuation and even gland-like spaces. And a subset have a more diffusely eosinophilic appearance, and kind of all of the cells have a plasmacytoid/rhabdoid appearance that can really help make you think of this diagnosis. They tend to be very cytologically monotonous, kind of like all these tumors we're talking about that have recurrent genetic alterations that kind of, despite their high-grade features, necrosis and mitosis, they do have some degree of cytologic monotony. And of course, the defining feature here is SMARCB1 loss. And again, the rest of the immunoprofile is heterogeneous. So you need to kind of think of these tumors across a wide range of staining patterns. Now, SMARCB1 also is lost in a subset of sinonasal adenocarcinomas, and this was a fairly recent finding. Importantly, these tumors can actually mimic germ cell tumors, specifically yolk sac tumors. They can kind of have a histologic similarity to that, as well as frequent positivity for glypican-3 and SALL4. The thought is that maybe a lot of tumors in the sinonasal tract that were previously thought to be germ cell yolk sac tumors are actually SMARCB1 deficient adenocarcinomas. The clinical implications of the glandular differentiation is unclear. All of these tend to be pretty aggressive tumors. Here's an example of a SMARCB1 deficient adenocarcinoma with overt, instead of just the gland-like vacuolated spaces, this has overt mucin production, mucin vacuoles within the tumor cells, and still does have those kind of oncocytic to rhabdoid-looking cells. And again, it has loss of SMARCB1, INI1 by immunohistochemistry. Now, a newly more emerging group of SWE/SNF deficient sinonasal carcinomas, also described by Abasagami, were SMARCA4 deficient sinonasal carcinomas. These seem to be rarer than SMARCB1 deficient, but they are defined instead by loss of SMARCA4. And they have a variable immunophenotype as well. Many of them have positivity for neuroendocrine markers, specifically patchy or weak positivity for synaptophysin. And many of them were actually previously classified as neuroendocrine carcinoma rather than sinonasal undifferentiated carcinoma. Here's an example of the SMARCA4 deficient sinonasal carcinoma with kind of a very high-grade undifferentiated small cell or large cell morphology that definitely makes you think of a high-grade neuroendocrine carcinoma. Here's another example from our institution that actually had a much more rhabdoid appearance that was similar to what we see with the SMARCB1 deficient sinonasal carcinomas. And a beautiful loss of SMARCA4, of course, helps you make this diagnosis. So clinical implications, both SMARCB1 and SMARCA4 deficient carcinomas are highly aggressive. They require aggressive multimodality therapy for management and really bad 5-year disease-free survival. There are treatment implications going forward. EZH2 inhibitors and bromodomain inhibitors have both shown some promise in other tumors that have these molecular alterations, as well as immune checkpoint inhibitors. So, there's some hope that these genetic alterations will translate into clinical benefit going forward. Now, one last new member of the SWE/SNF complex family is sinonasal teratocarcinosarcoma. And, this is an aggressive neoplasm unique to the sinonasal tract, defined by intermixed neuroepithelial, squamous and glandular epithelial components, as well as mesenchymal elements. So 3 different intermixed components. And despite the name terato suggests a teratoma, they don't have conventional germ cell components. And historically, these tumors have been challenging, very difficult to diagnose on small biopsy specimens when you only get, one of the tissue components can be a real pitfall. But there's also been a lot of controversy about their pathogenesis and etiology. So just examples of what they look like. Here's a nice example showing intermixed epithelial, mesenchymal, and neuroepithelial elements. Go in a little higher power on all the elements. The epithelial elements, the squamoid areas, tend to have this fetal appearance with this clear cell appearance, solid nests often. They can also have gland formation that can have a varying appearances. This is a very mucin-producing gland here. The mesenchymal components can be variable, ranging from kind of something like this, which is a hypercellular, nondescript spindle cell proliferation, to overt heterologous elements, including osteoid or chondroid matrix, rhabdomyoblastic differentiation. Everything is possible in the mesenchymal elements. And also the third component then is primitive neuroectodermal tissues, which show scant cytoplasm and neurofibrillary background. So all of these components tend to be mixed up together for sinonasal teratocarcinosarcoma. Having all these elements has led to some controversy historically about the histogenesis of these tumors. Do these tumors really derive from germ cell origin? They're generally not associated with other germ cell components. Do they arise from some sort of pluripotent stem cell that can give rise to the different tissue components? Or do they represent divergent epithelial differentiation of a high-grade neuroectodermal tumor? All of these options have been posed in the literature, and I think all of them have been very reasonable, but they have not historically been well characterized on a molecular level. A couple years ago, we published a paper that actually showed that the majority of sinonasal teratocarcinosarcomas have SMARCA4 loss and probably do fall in the SWE/SNF family. So we found that 82% had some degree of SMARCA4 loss and 68% had complete loss, and backed it up in a few cases with NGS. And this was very interesting because it was really the first recurrent somatic mutation identified in teratocarcinosarcoma, and suggesting that it is on a spectrum with SMARCA4 deficient sinonasal carcinoma and is not truly a germ cell tumor or of neuroepithelial origin. It also gave us a very useful tool in SMARCA4 immunohistochemistry for confirming the diagnosis in equivocal cases in limited biopsy material. Now, even then, though, when we published this paper, we knew there was probably more going on than SMARCA4 loss. There was a paper published in 2017 that found a CTNNB1 beta-catenin mutation in one case. Another paper showed PIK3CA mutation. And even in our paper, we did have a significant subset of cases that had partial SMARCA4 loss or retained SMARCA4 immunohistochemistry. So we knew that these were not a pure group. So recently, we've done more molecular analysis on this, and this is something that's not published yet. We're hoping to submit this soon. And in 14 cases that we sequenced, by and large, mirroring the immunohistochemistry, SMARCA4 was definitely the most common molecular alteration. But CTNNB1 mutations were also very, very common and frequently occurred in combination with SMARCA4. Overall, the immunohistochemistry and molecular findings lined up really nicely that partial or complete SMARCA4 immunohistochemical loss was seen in cases with SMARCA4 inactivation molecularly, as well as CTNNB1 activating mutations or a combination thereof. And tumors with intact SMARCA4 immunohistochemistry tended to have other mutations. There were other Wnt pathway mutations like APC, and as well as SWE/SNF mutations, complex mutations such as ARID1A, even SMARCB1, as well as some cases that had other less specific molecular alterations. So overall, this molecular findings also seems to support a link between teratocarcinosarcomas and sinonasal carcinomas, because all the mutations seen in teratocarcinosarcoma have previously been reported in sinonasal carcinomas with neuroendocrine differentiation. Of course, there's the SMARCA4 deficient carcinomas that have neuroendocrine differentiation that seem to be on a spectrum, but sinonasal neuroendocrine tumors, a nice paper out of Memorial Sloan Kettering that sequenced those, found CTNNB1, ARID1A, and APC mutations. This I think all provides additional evidence that teratocarcinosarcoma is probably best considered in the carcinoma lineage rather than a germ cell tumor. And both SMARCA4 and beta-catenin immunohistochemistry can be helpful, but not entirely sensitive for the diagnosis. But I'm going to emphasize right now, even though this molecular is really interesting and helps us figure out what these tumors are, teratocarcinosarcoma is still a morphologic diagnosis. It's not defined by SWE/SNF involvement, and we can still make this diagnosis kind of regardless of SMARCA4 or beta-catenin immunohistochemistry. So this is not yet a molecularly defined tumor. So in the WHO, sinonasal carcinomas, the SWE/SNF complex, deficient sinonasal carcinoma is officially a category now that has been recognized with 3 different subtypes: SMARCB1 deficient sinonasal carcinoma, SMARCB1 deficient sinonasal adenocarcinoma, as well as SMARCA4 deficient sinonasal carcinoma. And teratocarcinosarcoma is now listed in the sinonasal carcinomas categories, but it is still considered a separate entity that, again, is defined by morphology, not by molecular, although it's given us a better idea what's going on. All right, so my last 2 things I'm going to talk about today are a little bit quicker, kind of more emerging categories where molecular analysis is really helping us out in the sinonasal trend. And one of these is our sinonasal carcinomas that show IDH2 mutations. And sinonasal undifferentiated carcinoma, this has historically been a diagnosis of exclusion. It's a high-grade carcinoma, and it doesn't have squamous differentiation, doesn't have glandular differentiation, doesn't have neuroendocrine differentiation. I'll put a little caveat by that because that's evolved over time, and it's still evolving. But basically, this is a tumor. We have keratin positivity, but we can't put in any other sinonasal tumor category. We call it a sinonasal undifferentiated carcinoma. And here's a nice example of a sinonasal undifferentiated carcinoma: sheets of high-grade cells, prominent necrosis. These, do tend to have some more nuclear pleomorphism than some of the fusion-driven tumors that we were seeing, with numerous mitotic figures, atypical mitotic forms, as well as prominent nucleoli. Now, a few years back, a couple papers from Vicki Joe out of Brigham, as well as out of the Memorial Group, showed that sinonasal undifferentiated carcinoma, about 50 to 80% of residual tumors in that category actually had IDH2 mutations. And there were several recurrent hotspot mutations that were found. And interestingly, these were recognizable via mutant-specific immunohistochemistry, which actually provided a specific confirmatory marker for SNUC that we could use as opposed to making it a diagnosis of exclusion. Here's a nice picture of the IDH2 immunohistochemistry. We have it in our lab, and I find it to be very useful in working up sinonasal carcinomas and providing that positive evidence to make the SNUC diagnosis. Now, the question of neuroendocrine differentiation in SNUC has always been an interesting one, because originally SNUC was defined by excluding squamous and glandular components, but it actually was allowed in the initial paper to have some neuroendocrine differentiation. This has evolved over time, and the current definition really doesn't allow neuroendocrine differentiation. But this has been a source of persistent confusion, and different people have used different thresholds over the years for differentiating sinonasal undifferentiated carcinoma from sinonasal neuroendocrine carcinomas and olfactory neuroblastoma. And I think it can be a very hazy category in the literature that creates a lot of diagnostic challenges. So here's an example of a large cell neuroendocrine carcinoma that really kind of illustrates morphologically the similarities with SNUC. These, are arranged more in nests. We think of with large cell neuroendocrine carcinoma tends to have more of a central necrosis in a comedo pattern. Often the cells have abundant cytoplasm, prominent nucleoli, which are actually similar to SNUC. So there's some definite morphologic similarities. However, large cell neuroendocrine carcinoma shows well-developed evidence of neuroendocrine differentiation by immunohistochemistry that's not currently allowable in SNUC. And here's INSM1, our relatively new nuclear marker of neuroendocrine differentiation that is diffusely and strongly positive here. Now, interestingly, this all ties together through molecular, because IDH2 mutations have also been recently reported in sinonasal large cell neuroendocrine carcinoma. And this suggests that large cell neuroendocrine carcinoma is truly on a spectrum with sinonasal undifferentiated carcinoma. So older studies that relied on similar morphology between SNUC and large cell neuroendocrine carcinoma and kind of ignored the immunohistochemical differences between them were actually right on, and these tumors are probably part of the same spectrum. Now here, as an example of a large cell neuroendocrine carcinoma that has nice IDH2 mutant positivity. And again, this is picking up the mutant protein and showing the abnormality. Now, DNA methylation profiling is sort of emerging as a new tool that we can use in the sinonasal tract for grouping tumors into different categories. It's really shown some very interesting results in the neuropathology world, CNS tumors, as well as it's starting to in soft tissue tumors. And it's something that's starting to emerge in the sinonasal tract too. And this is another nice study out of Memorial that did methylation profiling on SNUC and large cell neuroendocrine carcinomas that both have IDH2 mutations, and showed that they have a similar methylation profile, and when kind of plugged into an algorithm, cluster together and are probably, again, still on the same spectrum. And also, regardless of whether it showed large cell neuroendocrine carcinoma histology or SNUC in terms of immunohistochemical differentiation, IDH2 mutant carcinomas in general had a better prognosis than SMARCB1 deficient sinonasal carcinomas or other SNUC that had unclassified molecular alterations. So this actually also provides a potential treatment target. Isocitrate dehydrogenase is an enzyme that catalyzes oxidative decarboxylation of isocitrate, part of the Krebs cycle, which we all hate to memorize in med school. And there's mutations in IDH1 or IDH2 genes can lead to abnormalities. And these are seen in a wide range of other tumors that alter the enzyme activity to create an oncometabolite. And IDH1/2 inhibitors can actually induce differentiation and have been pretty successful in other IDH mutant tumors and are a potential target for treatment in the future. So one question then is, should, now that it seems that these IDH2 mutants are there in SNUC and large cell neuroendocrine carcinoma, should we really have a IDH2 mutant sinonasal tumor category that is defined by the presence of this molecular alteration, as opposed to putting these in different categories that were historically just immunohistochemically defined? And that's not a resolved issue yet. The 5th edition WHO classification still keeps with our traditional morphologic and immunohistochemical categories of SNUC and large cell neuroendocrine carcinoma, but I think that certainly has now dramatically altered our understanding of the pathogenesis. And I think the question will be in the future whether we need an IDH2 mutant category that includes tumors from both of these groups. All right, so the final thing I want to touch on really quick before I'm done today is a very new diagnosis of olfactory carcinoma. And olfactory carcinoma is probably something many of you have not heard of before. So I'm going to start with something all of us have heard of, which is olfactory neuroblastoma. And of course, this is a very familiar, common sinonasal tumor. It's neuroendocrine neoplasm that is arising from the olfactory neuroepithelium at the superior aspect of the nasal cavity. And of course, this is one of the neuroendocrine tumors that's toward the neural end of the spectrum. It displays well-developed evidence of neural differentiation with lobulated and nested growth, fibrillary matrix material, as well as rosette formation. Importantly, it also lacks significant epithelial differentiation. In terms of working up sinonasal small round blue cell tumors, keratin negativity is very important for making a diagnosis of olfactory neuroblastoma. And although there's some controversy, and I think over time different groups have used different thresholds, both in the 4th and 5th edition WHO really only allows for focal low molecular weight cytokeratin positivity for diagnosis of olfactory neuroblastoma. And interesting, olfactory neuroblastoma, even though this tumor has been very well established for a very long time, there really is not a recurrent molecular profile known. And there have been many large sequencing studies that have not shown recurrent genetic alterations yet. So certainly I'm certain something's going on, but we haven't yet figured it out. Here's a nice example of an olfactory neuroblastoma, solid lobulated and nested growth, higher power. This is a low-grade example that has beautiful neurofibrillary stroma that sort of speaks toward its neural origin. Okay, so we're all very familiar with olfactory neuroblastoma, but there have historically been tumors that have been really hard to classify that show some overlap with olfactory neuroblastoma, histological resemblance, but also show well-developed epithelial differentiation and really contravene that notion that you only can have a little bit of keratin positivity. And these have not been well classified over the years. There have been a lot of previous names that these tumors with this appearance have been put into. Some have been lumped into the olfactory neuroblastoma category, which has created some confusion about how much keratin we should allow in olfactory neuroblastoma. Some described as olfactory neuroblastoma with divergent epithelial differentiation, mixed lineage olfactory neuroblastoma, olfactory neuroepithelioma, olfactory carcinoma, which is kind of our favorite name, which I'm going to come back to, mixed olfactory neuroblastoma and carcinoma, blastomatous variant of high-grade sinonasal adenocarcinoma, high-grade carcinoma of probable olfactory neuroepithelial origin. So there's like a ton of different names that have been used to describe a similar phenomenon of tumors that look like olfactory neuroblastoma but have epithelial differentiation. Now, we just recently put together a large multi-institutional study with the help of a lot of fantastic colleagues looking at these tumors. And we found 53 of them. So even though this is something that's not well established in the literature, it's actually something that it's not hard to find when you start looking around. They're rare, but it's something I think most people have run into. Predominance of men, and actually fairly young median age of 47 years, really occurs across the age range, and a significant subset of patients are younger than 40 years old. Almost all, like olfactory neuroblastoma, are centered in the superior nasal cavity around the cribriform plate, but they tend to behave quite aggressively, with progressive disease at a median of 8 months in almost 50% of patients, and death of disease in 30% in really very limited follow-up in our study. Now, to give you a sense of what these look like, here's some pictures. Here's a nice example showing the similarity to olfactory neuroblastoma with solid lobulated and nested growth and neurofibrillary stroma. This tumor had a ton of neurofibrillary stroma, even some ganglion-like cells in there. But a lot of these tumors also show sort of more expansile, solid growth of a neuroendocrine component. And rosette formation is very common. This is very beautiful rosette formation. And often these expansive neuroendocrine looking areas have a very high grade appearance with a lot of nuclear hyperchromasia, angulation, mitotic figures, apoptotic bodies, etc. Now, interestingly, the epithelial differentiation in these tumors can come in two forms. One of them is immunohistochemical, but you can also see overt gland formation. And these are not just individual small glands that might be entrapped. These are complex, proliferative-looking glands that tend to be a little bit blander than the neuroendocrine cells around them, but do have some degree of cytologic activia and proliferative activity that suggests they're part of the tumor and not just entrapped. Frequently, these glands actually have overt cilia formation. You can see beautiful ciliation, and this is something that was seen in more than half of the tumors that had glands, that the glands were actually ciliated. But of course, there's keratin positivity too to support the epithelial differentiation. It's stronger in the glandular component, but it's there in the neuroendocrine component as well. We can kind of see it in the areas of rosettes, kind of a weaker cytokeratin positivity. And tended to be non-focal more than 10% in all of the tumors in our series. Olfactory carcinoma, also consistent synaptophysin positivity, good neuroendocrine differentiation throughout the primitive cellular component. And it also showed S100 positive sustentacular cells, which is also something we historically have thought of as very specific for olfactory neuroblastoma. So these are really unique tumors. They have epithelial differentiation with glands and keratin positivity that sets them apart from olfactory neuroblastoma. They have neural elements, though, that set them apart from sinonasal neuroendocrine carcinomas. And they do not have the stromal elements of sinonasal teratocarcinosarcoma, even though they might have the glands and neuroepithelial components. So they don't really fit in a category, any category that exists that has been defined. So we argued in our recent paper that we should recognize these as a separate category, and we proposed the name olfactory carcinoma. And we can't take credit for that name. Both Raja Sathala and Bruce Wenig have published that name in the past, and we totally agree with them that it's kind of the best descriptor of them that reflects their unique features. The neuroepithelial differentiation seems to represent a recurrent and distinctive histologic pattern. It's associated with a characteristic clinical profile and aggressive behavior. And we think recognizing these tumors under unified terminology instead of forcing them into the olfactory neuroblastoma or other categories would actually be kind of the best way to understand them better. But even with that being said, these the fact that this is clearly a recurrent morphologic category, I think there's still a little question mark. There's a lot of similarities to olfactory neuroblastoma. Are they related? Are they related to other sinonasal carcinomas? So this is also unpublished data that we're just putting together now, but we were able to do molecular analysis on a subset of these. We have several more underway, so we're going to have some more data, and actually found that these tumors also had recurrent Wnt pathway or SWE/SNF complex alterations. There were 9 cases of the ones that we sequenced that had either of these alterations, 3 with Wnt pathway alterations alone, 3 with SWE/SNF alterations alone, and 3 with both. And CTNNB1 and PPP2R1A, which is a less common member of the Wnt pathway, were kind of the most common genes in that category. And then both SMARCA4 and SMARCB1 and ARID1A alterations were seen with SWE/SNF alterations. Interestingly, there was also a case that had an IDH2 hotspot mutation, which suggests that they might also, a subset of these might be related to the IDH2 mutant sinonasal carcinoma category. So these molecular relationships are interesting. The Wnt and SWE/SNF alterations kind of set olfactory carcinomas apart from olfactory neuroblastoma. Like I said before, olfactory neuroblastoma doesn't have recurrent molecular profile, and it definitely has not had any of these alterations recurrently in existing literature. And it really likely represents a separate pathway of disease. It also suggests that they're related to sinonasal neuroendocrine carcinoma and teratocarcinosarcoma, similar to some of the data that I presented earlier. And there really may be a spectrum of tumors with neuroendocrine and neuroepithelial differentiation that range from neuroendocrine carcinomas that really just have a neuroendocrine epithelial component to these mixed olfactory carcinomas that show the neural differentiation to sinonasal teratocarcinosarcomas that have stromal elements mixed in. So it seems that there's some similarities and differences going on here. And of course, IDH2 mutations that suggest that some may be IDH2 mutant carcinomas, and there's definitely sort of more emerging there in our data that will come out later. So 5th edition WHO classification, where does olfactory carcinoma go? This is not a category that has a home yet. This is something that's really too new, has not been recognized in the new WHO, and is kind of we're just trying to figure it out now. So we'll see where this comes by the time we have the next WHO down the line. All right, so really quick, just to sum things up, molecular analysis in sinonasal tumors has really changed the way we think of a lot of sinonasal tumors. It's allowed us to define and recognize multiple new diagnoses, understand the pathogenesis of existing tumor types, as well as clarify relationships between previously separate entities. Practically speaking, the molecular data is partially integrated into the new 5th edition WHO with recognition of new entities. Fortunately for us, most relevant findings, SNF complex, NUT, are all recognizable through immunohistochemistry or in situ hybridization, which allow us to make these diagnoses without doing full sequencing. Comprehensive molecular analysis is really not yet routinely performed on sinonasal tumors, but it really provides helpful and diagnostic and prognostic biomarkers going forward. It has not yet impacted the standard of care treatment, and that is something that I think there's a lot of promise for that I've touched on in several places, but it's not changing what our clinicians do at this time. So is a further molecular classification coming? Are we moving the way of the CNS WHO, which is now essentially entirely molecularly based? There's already proposals in the literature for completely subclassifying squamous cell carcinoma by molecular alterations, including some of the ones I talked about today and some others. Of course, this risks making already challenging sinonasal tumor diagnoses inaccessible for many pathologists, and I think it's a significant concern, as well as the cost of the sequencing and the greater treatment consequences may actually be necessary to justify billing for that. More categories are coming down with the pipeline with things like olfactory carcinoma. So I think this is still a emerging area, but we'll see how this continues to go in the future. But it is certain that molecular analysis will continue to inform our understanding. All right, that is all I have. Thank you so much for coming, and I'm happy to take any questions.
Thank you, Lisa. That was excellent and sound. And I also like to acknowledge some of our previous eminent speakers in the audience as well. As said, please type the questions that you may have in the chat function. Lisa, I don't know if you can see the questions, or should I read them to you?
I think I can see them, and you can let me know if I'm...
Yeah, let's start from the top.
Yes. All right.
Yeah.
So first question from Ramil, how are the HPV squamous cell carcinomas treated differently than conventional sinonasal squamous cell carcinoma? And that the answer to that is no. They are still treated the same way, and unlike in the oropharynx where HPV is now included in different staging, they're not staged differently either. So it really is considered still one treatment regimen for sinonasal squamous cell carcinomas, regardless of HPV status. I think practically speaking, it's not really treatment, but in terms of disease monitoring, the closest implication out there is the fact that there are serum testing for HPV, and our clinicians at Hopkins are absolutely in love with this, and really have picked up several early recurrences in both the oropharynx and sinonasal tract using serum testing for HPV. And I think practically speaking, that's the first implication for HPV in the sinonasal tract, that we can follow these patients using serum studies and potentially pick up early recurrences. So next question from Robert Kelsch. Do you anticipate a decrease in these HPV-related sinonasal carcinomas in the future with increased HPV vaccination, even with some of them HPV-33 related? And that is a great question. I certainly hope so. I certainly, I don't think we, of course, I'm in the U.S. and we haven't done a fantastic job at getting these vaccines out to everyone, but other countries, I can think of Australia for sure, as well as other locations that have done a really fantastic job. And I think we'll be able to, we've already seen in those countries decreases in cervical cancer, so one can really hope it will happen in the head and neck as well. I think there was a modeling study from the School of Public Health here at Hopkins that suggested it would probably be 20 or 30 years down the road before we really started seeing oropharyngeal squamous cell carcinoma decrease in the U.S., partially just due to our vaccine coverage, but hopefully that will start happening. That's what we all want. From Liam Robinson, do you feel it's necessary to determine which is the partner gene to NUT-M1 and NUT carcinoma? Literature seems to put better survival with different partners. Yeah, that's an excellent point. There's definitely emerging literature that various partners are associated with better prognosis. I think also various sites are associated with better prognosis. Unfortunately, the sinonasal tract is not one of those sites that they tend to be aggressive. There hasn't yet been a big call here in terms of finding the partner for prognostication. I think they're going to treat them aggressively regardless of the partner. I don't think they back off on the treatment based on a better prognosis partner. I think that's definitely, it's a horrible diagnosis, and I think it's definitely information. that I like to provide if possible to, give them a little shred of hope. But unfortunately, I think, it's not something that's necessarily easy to test for. I think we have a fusion panel here that we use that covers some but not all of the fusion partners. So it's something that we'd actually have to send out for. So there hasn't been a big emphasis on it yet. But I think it's, again, a little bit of positive information we could give to some of these patients if possible. All right. In case of not having any molecular devices, are there any immunohistochemical stains being specific to DECAF2 carcinoma? That is a great question. There was actually a fantastic presentation at USCAP from Jianfan Heng's group out of Taiwan that has an AF2 immunohistochemistry. So I'm super hopeful that might be something that might soon be available to more of us for making this diagnosis. I should add with the DECAF2 carcinomas, this is really hard to test for so far. ProPath in Dallas has a FISH which has been successful and has helped us clinically make the diagnosis. But I know a lot of people don't have DEC or AF2 on their sequencing panels yet. So hopefully this immunohistochemistry will come down the line. I think hopefully there'll be a paper about that coming out shortly from, again, Jianfan Heng's group that can really maybe give us a diagnostic tool. All right, from Annie, how far should one go in terms of specific IDH2 testing in SNUCCY tumors? I've pushed and not pushed surgeons regarding confirmatory genetic testing. Does confirmation of IDH2 mutation allow for different, better treatment of the patient? Yeah, this is a great question too. And this is kind of where, if this is a limitation of my talk today, I think in terms of all we're doing, I think we're ahead in terms of understanding the pathogenesis of these tumors compared to what we're doing with treatment. We're still treating most of these tumors the same. I think, sometimes if you do molecular analysis and then find an IDH2 mutation, it definitely can qualify patients for kind of the basket trials that are looking at different types of molecular, kind of look across tumors, trying to pair targeted therapies with molecular alterations. But in terms of standard of care therapy, they're really not doing anything differently. So I think IDH2 immunohistochemistry can be really useful for confirming something is in that SNUC category and you're not missing something else and diagnostically, but right now it's not making them do anything different. Of course, again, prognostically, I think it's more promising in that we know the IDH2 mutant tumors are it's an aggressive group, but they do better than the SMERP1 deficient tumors. How specific beta-catenin nuclear/cytoplasmic staining is for teratocarcinosarcoma? That is an excellent question, and I don't think we know the answer to that yet. Definitely, beta-catenin in general stains a lot of sinonasal tumors. Some of them don't necessarily overlap with sinonasal teratocarcinosarcoma, but there's mesenchymal neoplasms that have it. We know it's present in some sinonasal adenocarcinomas. So I don't think it is entirely specific. I think it can be helpful if you have something primitive that you're kind of getting morphologic vibes, might be a teratocarcinosarcoma, but you might not have all the elements there on biopsy or anything like that. So it's not something that out of context should be an absolute. Let's see. Thank you to everyone's thank you. Let me see one more question down here. Are any of these newly defined molecular alterations in sinonasal tumors also studied in the context of conventional head and neck squamous cell carcinoma? If we're thinking of molecular classification, where do we currently stand for conventional squamous cell carcinoma? That is a great question. And I don't think we've looked broadly for everything in conventional squamous cell carcinomas. I think we definitely haven't done a broad look for DEC AF2 fusions kind of across the spectrum. We really focused, I think the studies that are out there focused on sinonasal tumors that are non-keratinizing, HPV negative, but across the spectrum, could it be there and more? I think there was a study a few years back from Hopkins that did look for fusions broadly in oral and laryngeal squamous cell carcinomas and didn't find any. But at that point, I don't even know if DECAF2 would have been something that people would have been looking for, since those genes are not commonly implicated in cancer. So I think there still needs to be a broader look across the spectrum for these emerging fusions. And then let's see, one more. aside from association with HPV, have groups been successful in sequencing HPV-related multiphenotypic sinonasal carcinoma to identify recurrent underlying genes involved? That is a great question. I'm aware of one group in Europe, I think, that's doing that right now. I'm not familiar with their results. I know we have looked for fusions in them and have not found any fusions, and that would be like the MIB fusions as well as any other fusions. So I think it's a good question in terms of whether they have the same genetic alterations, molecular underpinnings as other HPV-related tumors, or what else is there that's driving that kind of salivary phenotype. All right, don't think I missed anything.
That looks like a whole lot. Lisa, thank you. I mean, on behalf of everybody from the States, in Europe, in South Africa, in Asia, it's always great to listen to an expert, and you really are. Thank you for your systematic approach to this group of lesions, and linked to that, your excellent photomitographs, both H&E and immunohistochemistry. We have really been spoiled today, and from our side, again, thank you very much for the time and being prepared to chat to us. Much appreciated. And to everybody else, thank you for listening. Be on the lookout for our next guest speaker, which will be announced shortly. Thank you, everybody, for joining, and have a great day further. Again, Lisa, thanks a lot.
Thank you so much for the invitation. Thanks for coming, everyone.